Welcome to this practical overview of cesarean section, intended for educational purposes only. Real-world surgery must be performed by qualified obstetric surgeons in a fully equipped operating theater. Preoperative preparation begins with confirming the indication, such as fetal distress or placenta previa. Informed consent requires explaining the procedure, risks, and alternatives, then obtaining written consent. Patient assessment includes vitals, labs like CBC and coagulation, blood cross-match, and fasting status. A team brief involves the surgeon, anesthetist, scrub nurse, neonatologist, and circulating staff reviewing roles and equipment. Positioning is supine with a left lateral tilt of 15 to 30 degrees to relieve aortocaval compression with arms secured. Prophylaxis includes 4 antibiotics like cefazolin within 60 minutes of skin incision and antithrombotic measures per protocol. Anesthesia choice is usually spinal or combined spinal epidural, with general anesthesia if contraindicated. Monitoring involves ECG, pulse oximetry, non-invasive VP, capnography, and continuous fetal heart rate. Surgical steps begin with a transverse phalansteal skin incision, about 2 centimeters above the symphysis pubis. Next, the bladder flap is created by dissecting the bladder peritoneum and pushing the bladder caudally with a moist swab. A low transverse uterine incision is made in the lower segment, avoiding the cervix, extended with blunt dissection or scissors. Delivery involves gently lifting the fetal head, applying upward traction and fundal pressure from an assistant, then clamping and cutting the cord. The placenta and membranes are delivered spontaneously or with gentle traction, then inspected for completeness. Uterine closure uses a single-layer running absorbable suture for the myometrium, with an optional second layer for hemostasis. Peritoneal and facial closure involves closing the peritoneum optionally, then the rectus fascia with a continuous absorbable suture. Skin closure is performed with a subcuticular absorbable suture or skin staples, followed by a sterile dressing. Postoperative care includes transfer to PACU, monitoring vitals, uterine tone, and lochia. Analgesia involves 4 opioids and NSAIDs if not contraindicated, and early ambulation is encouraged within 6 to 12 hours. Antibiotic prophylaxis continues for 24 hours per local protocol, and immediate neonatal assessment ensures skin-to-skin contact if stable. Key safety points include having oxytocin ready for hemostasis and blood products available for potential blood loss. Clear team communication is vital, announcing milestones like baby's head is out and placenta delivered. Thorough documentation of timings, drugs, vitals, and complications is essential. Remember, this outline is a generic reference. Actual technique may vary based on patient anatomy, institutional guidelines, and the surgeon's judgment. Always follow your hospital's standard operating procedures and seek direct supervision from a qualified obstetric surgeon.